Good afternoon or good morning to all of you, and welcome to this webinar on approaches to characterization of very high fracture risk. My name is Dominique Pierrot, and I'm the science manager at IOF. Before introducing the speaker of the day, I would like to inform you that attendees are automatically muted. I also would like to encourage you to ask questions during the webinar by typing them into the question box of the control panel, and I will voice them to the speaker towards the end of this webinar. I would like to thank Amgen for their support to this webinar. This being said, it's my great pleasure to welcome today Professor Cyrus Cooper. I don't think I really need to introduce him, but just in a few words, Professor Cooper is Professor of Rheumatology and Director of the MRC Life Course Epidemiology Center in Southampton and Professor of Musculoskeletal Science at the University of Oxford. He leads an internationally competitive program of research in the epidemiology of osteoporosis and musculoskeletal disorders and has published extensively. And Professor Cooper is the president of the IOF. So Professor Cooper, it's a pleasure to have you today, and we look forward to your presentation. I'm going to give the control of your slide now.
Thank you.
Perfect.
Is my screen up? Perfect.
Everything is perfect.
Thank you. Thank you very much indeed, Dominique. Good day to all of you, and thank you for coming along to this IOF Bonecast webinar. As Dominique said, I'm going to tell you about approaches to the characterization of very high fracture risk. I'll cover for you the information we have that's bang up to date on the fracture burden, principally in Europe, and the treatment gap that persists. Talk a little bit about guidelines for risk assessment and treatment, before turning to secondary fracture prevention and the time course of subsequent fracture risk, because it's that has made very high fracture risk a really important topic today. And we'll then turn in the bulk of the webinar to the approaches that we have for estimation of imminent or very high fracture risk. So first of all, the fracture burden and the treatment gap. We've just published through John Keynes's excellent SCOPE report on the growing burden of osteoporotic fractures throughout the European Union. They now account for 55.3 billion euros each year. That's 3.5% of the total EU healthcare spend. And as you can see in the bottom right from this manuscript published in the archives earlier this year, that the annual number of fractures will increase from 4.28 million each year in 2019 by 2034 to 5.34. And this represents a 24.8% increase over that intervening decade and a half, and it is, of course, accounted for 50% by fractures at the hip, vertebral body, and forearm. So 19% of all fractures in women and men will be at the hip, 16% at the spine, coming to clinical attention, and 15% at the distal forearm. But 50% is left over for fractures at other sites linked to osteoporosis. Of course, most importantly, the other major osteoporotic fractures such as pelvis, scapula, ribs, sternum, proximal humerus, and then, of course, throughout the skeleton. We also know that 25.5 million women and 6.5 million men, amounting to 32 million adults overall, have densitometrically proven osteoporosis, and this is among women aged 50 plus, 22.1%, and among men aged 50 plus, 6.6%. The report is also able to tell us about the reach of risk assessment and treatment, and the treatment gap. And you can see that the overall treatment gap at greater than 60%, with some countries having very high, very large treatment gaps, is leaving plenty of work to be done by all of us in narrowing this, particularly for those individuals who are at higher fracture risk. And of course, among the contributors to the treatment gap, and we've iterated those recently following on from a report that we published in 2017 at IOF, dividing up the contributors into case finding and management, aspects of public awareness, and government and health system issues. Among case finding and management, the primary contributor to the gap is inadequacy of our secondary fracture prevention systems. So now let's turn to the risk of a fracture once you've had a previous fracture. These are data published over 20 years ago by Joe Martin and myself, looking at the risk of fracture after an initial clinically diagnosed vertebral fracture. You can see that there's an elevated risk for a future vertebral fracture that is greater than tenfold in relative terms. There's a doubling of hip fracture risk and a 60% increase in distal forearm fracture risk, and increases in the risk of all these other major osteoporotic sites: pelvis, clavicle, scapula, sternum, and ribs. In addition to that relative risk increase, we were also able to look at the time course for future fracture after the sentinel vertebral fracture. And you can see that this picked up early. The idea of a rapid increase in fracture risk, the very high or imminent fracture risk, was known about as long ago as 2.5 decades. That but by the first year after the fracture, 20% of women and 17.5% of men had sustained a further low trauma fracture. This led to us incepting the Capture the Fracture initiative here at IOF, and in its earliest form, we promoted secondary fracture prevention systems through FLS services around the globe. And earlier this year, we'd recruited over 600 fracture liaison services in 48 countries, recording well over 500,000 fragility fractures. We had produced a best practice framework, we've produced a mentorship program, and we've published key performance indicators for this particular initiative. Natural experimental data, for example, these published by Kasim Javed, Daniel Prieto Alhambra, and Andrew Judge in the group, showed that there was a step change in anti-osteoporosis medication use, coupled with a decline in second fracture incidence following FLS initiation on a nationwide basis. And in the last couple of years, we've developed the Capture the Fracture partnership in a new direction, joining together the universities of Southampton and Oxford with the IOF and our corporate partners Amgen and UCB, aiming to increase by 50% the number of patients reached by these new post-fracture care fracture liaison services, and focusing on the countries shown in the bottom left of this slide in 2020 and 2021, going in alphabetical order from Brazil through to Taiwan. The policy component of that is noteworthy in that we've produced generic guidance for policy shaping with a pictorial infographic and executive one-page summary and country-specific documents for the countries that we're looking at, which are translated and all available on our website. Now, the notion that the risk function of a second fracture has an odd time course soon after the initial fracture, gained sway in the early 2000s and has been well summarized in this paper by Rafa Pinedo Villanueva in the archives a couple of years ago. It is important because we now have an expanded formation stimulating pharmacotherapeutic armamentarium. So teriparatide has now progressed to also the biosimilars for teriparatide and PTH derivatives, abaloparatide and romosozumab. And it is the coming of these two agents that has promoted our thought of intervening early with them rather than commencing anti-resorptive agents and holding back the formation stimulators for more severe osteoporosis later in the natural history of the disorder. And for romosozumab, the evidence linking it to bisphosphonate therapy is best summarized in the ARCH trial, where romosozumab to alendronate were compared with alendronate continuing as alendronate over a 4-year period. And the romosozumab to alendronate arm showed benefits for a variety of fracture sites, which had to be balanced with the small but clinically relevant adverse event of ischemic cardiac events. And we now have contraindications for previous ischemic cardiac events that guide us in how to use this agent. And we now know also that the sequence of drugs matters, that the older approach shown in yellow of an anti-resorptive agent for 8.5 years, followed by an anabolic for 1.5 years, is far less effective than the regimen shown in green, where an anabolic agent for 1.5 years is followed by an anti-resorptive for 8.5 years. And the difference between their anti-fracture effectiveness varies by a factor of almost twofold. So going back to the evidence of a very high imminent or immediate fracture risk, Olaf Chanel first demonstrated this for sentinel fractures at the shoulder and incident fractures, second fractures at the hip, spine, and distal forearm. And you can see how steeply the relative risk declines for years after the sentinel fracture, with this relative risk scale actually being logarithmic. And he showed, therefore, the great dividend that one might gain by early intervention. Those data have now been supplemented by a series of excellent papers from the FRAX group, this one based on the Reykjavik Icelandic cohort led by Helena Johansson. And you can see this similar exponential fall off in the relative risk of the second fracture, expressed here as the true incidence of that second fracture in years after the initial incident fracture. And that risk pattern is there with declining excess risk after the sentinel fracture with advancing age. So it's there at age 60, at age 70, at age 80, and at age 90. And if anything, becomes more pronounced in the older age categories. It's there regardless of the sentinel fracture. So it's there for the hip, for the spine, for the forearm, and for the proximal humerus. And it allows us to estimate really quite accurately what might be going on in the first couple of years using data from the 10-year estimate of risk from FRAX, as I'll show you later on. Other studies have also looked at the magnitude of imminent risk and its determinants. In this paper by Dr. Sorskog and colleagues using the Swedish National Registry, they characterized the risk of major osteoporotic fractures after an initial single fracture, or in women with 2 fractures, or in women who actually sustained a third fracture and had some degree of follow-up. Clearly, the sample who only had the first index fracture was largest at over 230,000 women. The group who had a second fracture were down at 39,000, and the group who had a third fracture down at only 7,000. But for each group, an accurate cumulative incidence of subsequent fracture could be mapped out, and this was elevated regardless of whether you were talking about a first sentinel, a second sentinel, or even a third, where the competing hazard of death will of course be playing a remarkable part. And then in the second study published from the Swedish registry, Esme Toth and colleagues identified those patients who had a primary diagnosis of a fragility fracture between January and December 2013, didn't have other causes such as Paget's disease or malignancy, and were aged 55 to 90 years. And they looked at what the subsequent frequency of incident fractures would be and what the past history of fracture would be in these women with subsequent non-hip, non-spine fractures. And you can see that at the older ages, particularly above 80, the proportion that have had a previous fracture rises to almost 50%. And they derive absolute cumulative incidence estimates annualized for 1 year and for a 2-year period, 12 and 24 months, depending on where the initial fracture is and where the subsequent fracture is. And these rates rise to above 10% when one is talking about any fracture over a 2-year period. So a remarkable imminent or very high fracture risk. And then the last register-based study comes from the Clinical Practice Research Data Link and in the UK, and the Spanish CIDIAP database and Danish health registries. And in large numbers of people, amounting to well over 500,000 in these three databases, looking at the magnitude of fracture risk 1 year after the sentinel fracture, you again see substantial incidence rates, even for site-specific fractures such as hip fracture, with 2% and 5% being observed in CIDIAP and the Danish registry. So that this magnitude of risk has been characterized, it is substantial and may approach 10% over a 2-year period. What are its determinants? So fewer studies have looked at the risk factors for imminent fracture, but the ones that emerge are shown here. Falls, use of opiates, functional impairment, comorbidities, and other CNS disease. And if one looks in a multivariate analysis, prior vertebral fracture, 4 or more Charlson comorbidities, antidepressant use, and each decade of age are all independent contributors in a multivariate model. So now let's think about approaches to characterizing very high fracture risk. And the first of these is based around our long-standing work at IOF and ESCEO using FRAX, and then adapting FRAX to the UK National Osteoporosis Guideline Group approach to risk assessment. So FRAX is now institutionalized in our Europe-wide guidelines for diagnosis and management of osteoporosis. We propose retaining the current WHO definition of a T-score below -2.5 based on DXA at the spine or hip. An individual then undergoes fracture risk assessment with the country-specific FRAX fracture probability using the risk factors shown here. And of course, prior fragility fracture is a key one among those risk factors. Vertebral fracture is defined using VFA, or lateral thoracolumbar radiographs if there is height loss or kyphosis. We then express the 10-year probability of a major osteoporotic fracture against age and have an intervention threshold illustrated in the right-hand graph if DXA is already available that is age dependent and equates to the 10-year probability of fracture in a woman who has average body mass index but has sustained a previous vertebral fracture at a t-score of minus 2.5. We also have, based on clinical risk factors alone, a lower and upper assessment threshold. In the United Kingdom, when we applied the intervention threshold for 3 or 4 years from 2012 onwards, there was a general view that too many women above the age of 70 were being deprived of treatment despite a very high fracture risk. And therefore, we moved to an age-independent threshold above age 70, and this is the NOG guidance for treatment in the United Kingdom. Over the last couple of years, John and his group have done a huge amount of work to take account of recency of sentinel fracture. In the first analysis published in 2020, they looked at the multiplier of the 10-year major osteoporotic fracture probability derived from FRAX if the fracture was within the first couple of years. And they applied these multipliers for fractures based around the initial fracture at the vertebra, at the hip, at the proximal humerus, or the distal forearm. And regardless of age, there was an excess risk for recency, as you would imagine, which tapers as you move to the older age categories. And the multiplier in the younger ages, say 40 to 49 and 50 to 59, are substantial. So these were provided and allowed an individual to calculate imminent or very high risk on the basis of this multiplier. And they looked at these 10-year probabilities, as I've shown, for major osteoporotic fractures as a whole and for hip fracture. And these nomograms were available to practitioners. They also allowed calculation of a 10-year, a 5-year, and a 2-year probability of major osteoporotic fractures in women according to where their initial fracture had occurred in the recent past. And you can see the integrated 10-year probabilities reaching rates for major osteoporotic fracture of over 30%, with 2-year probabilities around 10% at ages 70 or 80. We then looked at putting these into an algorithm for management of low, moderate, high, and very high risk of fracture. We started with the IOF-ESCEO management algorithm, where we had a lower and an upper assessment threshold. And these thresholds had been estimated, particularly the upper assessment threshold, at 1.2 times the risks of the intervention threshold. And at this 1.2-fold elevation of the intervention threshold, a very high risk group, we proposed that anabolic agents could be followed by inhibitors of bone resorption, the very high risk category. At the gap between the intervention threshold and this very high risk threshold, so IT and upper threshold, 1.2-fold higher, we would consider high risk to be the case and target oral bisphosphonate or other inhibitors of bone resorption. And below that would be moderate or low risk, in which reassurance, lifestyle advice, menopausal hormone therapy, and selective estrogen receptor modulators could all be considered. So those data were published in OI in early 2020. It seems a long time ago now, but it was only 18 months ago. Now, one of the difficulties with that was that the proportion of women who were classified as very high risk and therefore targets for anabolic therapy as a first-line approach was 16%. Earlier this year, John presented what might happen if we wanted age independence above the age of 70. Now, if you put the 1.2 multiplier for the intervention threshold as the determining factor for very high risk, you find that when you make it age independent above 70, so horizontal above 70, the proportion of women jumps to 23%, something that we found really difficult to justify on cost utility grounds in the United Kingdom. If you jump to double the intervention threshold, you find that the proportion of women in the very high risk group declines to just 5%, something which, although possible, felt a little conservative. And we therefore adopted, after much discussion, a 1.6-fold multiplier on the intervention threshold. And that gave us a frequency of imminent or very high risk of 10% of women. In the paper that came out just earlier this month in the Osteoporosis International, the way in which risk factors contributed to that very high risk was also illustrated. So single clinical risk factors such as family history, glucocorticoid use, secondary osteoporosis, it was very difficult to reach very high risk. In the very elderly, above age 90, prior fracture and parental history could reach it. But recent fracture was able to get to very high risk, and particularly when combined with other risk factors such as glucocorticoids, often got a patient to very high risk. So a treatment algorithm, as shown here, emerged, where on the basis of clinical risk factors, 10-year probability of fracture was estimated for major osteoporotic fracture. Very high, high, intermediate, and low could be assigned. In the intermediate group, BMD was used to reassess 10-year probability, and with recency incorporated, very high, high, and low were again able to be determined, and the algorithm that I've shown you could be used for the treatment of those at very high risk. There are also other approaches to characterization of very high risk, which I'll cover in the rest of this webinar. Probably the main group of other approaches are those based on registry definition of recent fracture, followed by multiple register-based historical or clinical risk factor variables that are recorded. Perhaps the most thoroughly worked up of these is the paper published in JBMR last month by Sarah Khalid, Daniel Prieto Alhambra, Bo Abrahamson, and a group of other collaborators. So in that study, the Spanish dataset was used as the discovery cohort. Lasso regression and logistic regression identified a model to predict the short-term risk of incident fracture, 1 year and 2 year timeframes. This prediction model was then externally validated using the UK Clinical Practice Research Data Link and the Danish Health Registry, just as I talked about the magnitude of imminent risk earlier on in the webinar. So in that analysis, looking at predictive tools, an incident fracture cohort and an oral bisphosphonate cohort was selected. And the incident fractures over 1 year and 2 years of follow-up in these two cohorts were looked at, and risk factors determining that incident fracture were developed. And the predictive models in the incident fracture cohort included age, gender, and the comorbidities and drug uses shown in the first bullet point. And in the oral bisphosphonate cohort, age, gender, and the comorbidities and drug use recorded in the second bullet point are itemized. But you can see that these are basically a list of multimorbidities and drug exposures that were recorded in these data sets. The discrimination characteristics of this predictive tool was really very encouraging for both 1 year and 2 year incidence. As you can see here, the areas under the curve for 1 year reaching in the incident fracture cohort greater than 0.75 and greater than 0.8 for the oral bisphosphonate cohort, and similar values being observed in the two cohorts for 2 years after follow-up of the sentinel fracture. Perhaps just as important, the observed versus predicted risk plots estimating calibration over a 1 year period after the sentinel fracture were also remarkably close. So the performance characteristics of this tool developed in the discovery cohort in similar pharmacoepidemiological databases for estimation of its performance were really very encouraging. And finally, the next stage of development of the electronic health record is to use machine learning once these predictive algorithms have been developed. And that was undertaken in a paper published by Drs. Almog and Stephen Cummings in the Journal of Medical and Internet Research last year, where 1 million patient records in a West Coast HMO were looked at. Machine learning and natural language processing was used to predict 1 to 2 years fracture risk. And again, there was very good discrimination and calibration performance with an area under curve of 0.81 reported. So plenty to go on there. What about expert consensus in addition to the IOF-ESCEO paper that was published in 2020? Well, the two that I want to share with you are the guidelines of the Endocrine Society and the guidelines from the Scottish Intercollegiate Guideline Network that have been published in the recent past. The Endocrine Society guidelines stipulate very high risk as being multiple spinal fractures and a T-score less than -2.5. And they use this particular clinical constellation to distinguish the treatment with anabolic agents in the first year or 2 years, romosozumab for 1 year, teriparatide or abaloparatide for 2 years in their care pathway, as compared with those at high risk who do not reach the very high threshold getting bisphosphonates or denosumab. And the Scottish Intercollegiate Guideline Network puts its threshold for very high risk or imminent risk as 1 severe or 2 plus moderate vertebral fractures, together with a T-score at any site of below -1.5 or a lumbar spine T-score below T of -1.4, of T of -4. So really a very severe DEXA threshold on its own, but a more plausible one for clinical practice of 2 plus moderate vertebral fractures with a T-score of -1.5. And again, they have a care pathway that separates out romosozumab and teriparatide in this group of very high-risk individuals. In trying to operationalize all of this for simple practical guidance, while we start to work towards a consensus between these different approaches. I had to chair a group in the UK with Kasim, and that incorporated a seasoned general practitioner, a seasoned FLS nurse, and a seasoned pharmacist engaged in osteoporosis practice and guidance. And when we looked at the whole piece, we were struck by how much consistency there was if one had a major osteoporotic fracture in the last couple of years, and one looked at a FRAX 10-year probability of a major osteoporotic fracture of 30% or higher. If one did that, one pretty much accommodated most of the current guidance. And that was the nearest I can get to the practical operationalization today. And that's certainly what I do in my head in the clinic today, while we wait for consensus to emerge between the various approaches that I've outlined for you, and perhaps even more that are being generated in the literature as we speak. And a good example of another one would be the Swiss guidance that Serge Ferrari shared with me, that's been published for the Swiss Osteoporosis Society. The good thing is that the different approaches do tend to converge in terms of similar 10-year fracture risks for hip fracture and for major osteoporotic fracture, as I've outlined. But I think the consensus of a single approach to very high or imminent risk prediction remains currently elusive, and was actually the subject of the most recent ESCEO workshop that Jean-Yves Regenster and colleagues designed for this purpose only a matter of weeks ago. And the manuscript for that is anxiously awaited by those of us interested in this issue. So to conclude, previous fracture is a major determinant of future fracture. Subsequent fracture risk varies with time following the sentinel fracture, and risk is particularly elevated, so-called imminent or very high risk, over the first 1 to 2 years after the sentinel fracture. There are other routes to similar levels of 10-year risk from other constellations of risk factors, for example, family history of fracture or oral glucocorticoid use, but probably the major route to a very high risk of fracture is from a recent previous fracture. There have been a variety of approaches to predicting the magnitude of this very high or imminent fracture risk. They include modifications of the FRAX algorithm with recency of fracture, which has been thoroughly worked up by John Canis and his colleagues. The proposals using registry-based systems that have been worked up by Daniel Prieto Alhambra, Bo Abrahamson and their colleagues here in the UK, and Stephen Cummings and his colleagues in the United States. And there are then expert approaches which have been proposed, for example, those by the Endocrine Society or the Scottish Intercollegiate Guideline Network. Guidance algorithms are available for how you translate from these very high risk prediction to treatment, and early treatment has been shown to be essential in the very high risk cases. So I leave you with a smorgasbord of approaches to predicting very high risk, but the certainty that once you have reached that very high risk, early treatment, particularly with our formation stimulating agents, is the order of the day soon after a recent fracture, and that with use of those agents for a short period of time, relatively, say 18 months to 2 years, or even 1 year in the case of romosozumab, following them with anti-resorptive therapy for the rest of the decade, will lead to a very healthy reduction in subsequent fracture risk. I do hope you will join me at the next World Congress in Berlin in 2022. and the subsequent one in Barcelona in 2023, to hear further chapters of this fascinating story in osteoporosis prevention and treatment. But other than that, I would simply like to thank all of the colleagues at Southampton, Oxford, ESCEO and IOF who have contributed to the work that we've undertaken on very high fracture risk, and welcome your questions, many of which I know, the answer of which will be that I do not know. Thank you very much for your time and enjoy the rest of your day. Thank you.
Thank you very much, Professor Cooper, for this very comprehensive presentation and for covering a topic that stimulates many questions. More and more questions are coming in the question box. I'm sure that your talks was greatly appreciated by our audience, and now I would like to move on to questions. So maybe the first one I'm going to ask you is, what is the difference between the IOF-ESCEO approach and the UK NOG1?
So the principal difference between the two stems from what I mentioned had happened when the Europe-wide algorithm had been introduced in the UK around 10 years ago. So as it became used, we found that above the age of 70, there were too many women that particularly our elderly care colleagues and primary care colleagues, geriatricians and GPs, thought were at high risk, but by our age-dependent algorithm were not getting treated. And in those days, the treatment was, of course, bisphosphonates. We weren't talking about teriparatide then. So in 2015, we recalibrated the European algorithm for the UK as the NOG algorithm so that above age 70, the threshold for treatment, for intervention, was horizontal. It was age independent, rather than continuing to rise exponentially as the previously published 2012 algorithm had done. And the impact of this was to allow us to treat many more older women at higher risk. When the very high risk issue first arose, we used the Europe-wide algorithm, which carried on smoothly increasing with advancing age, and picked the 1.2 multiplier for the line that distinguished the very high risk from high risk. But in the UK approach, we wanted to be horizontal above age 70. And when you use the 1.2-fold multiplier, so when you do what was done in the Europe-wide paper of 2020 in OI to the UK horizontal picture, you find that you end up with far too many women who would be treated with the formation stimulating agents, almost one which we knew our policymakers would not be happy with. And that is why we moved to a more conservative 1.6-fold elevation from John and his group. And it is that is the current sort of consensus in this sort of choice that has to be made. And that leads to about, as I indicated for you, 10% of the women being at very high risk in that red zone and being eligible, if you like, because principally of fracture recency. But as you saw, you could get there with a non-recent past fracture and glucocorticoid use, for example. But those are the women that we would consider for an anabolic or eligible for an anabolic first.
Many thanks for your answer.
Sorry, it was a bit lengthy, but it is important to try and get that sequence clarified.
Yes, sure. We have many questions related to the treatment. So, for example, one question from Dr. El Makbali is asking you if you can elaborate a bit more on the treatment modality for a patient with a high risk of having a second fracture.
Well, I suppose that the treatment modalities are, as I showed, formation stimulating agent early for 1 to 2 years, followed by anti-resorptive, rather than commencement with our traditional anti-resorptive therapy, say oral bisphosphonate or denosumab, and waiting to see whether risk then drifted upwards because the situation became even worse with further intervening fractures before we intervene with teriparatide or abaloparatide or romosozumab. So the difference now is that we would give teriparatide, a biosimilar, abaloparatide, or romosozumab, depending on what was available and the national formulary recommendations for each country. We would give those for the 1 to 2 year period of very high risk before switching to anti-resorptive therapy thereafter. And that's quite a profound change in behavior, and one which will be interesting to see translated into action in countries around the world. But that's the impact that this change of recognizing very high risk will have on how we use our therapies.
Thank you. And continuing on this treatment, there is a question from Dr. Cox from Sweden. She's asking if a patient on an anabolic treatment develops another fracture during the treatment, how would you approach the treatment regimen?
Yes, so that is I think that is a question that is really rather individualized to a particular case. So I could imagine approaching it in different ways depending on my interaction with that particular patient and the unique set of circumstances. So the choices are to accept that the anabolic treatment was started in the context of a very high baseline risk, and that the fracture was just an unfortunate stochastic event that happened in the natural history of the patient, and therefore that one should persevere with that anabolic therapy and see what had happened to the intermediary markers, for example, bone mineral density and the biochemical markers of bone turnover, by the end of, say, if it was teriparatide, the 2-year period, the 18-month period, if it was romosozumab, the 12-month period. But if, as does happen, and we've seen often with our anti-resorptive regimens over the last 2 decades, the patient has lost confidence in the regimen as a consequence of the second fracture, and one is in a position where the patient just does not want to carry on with anabolic therapy, then of course I would feel better off being on some form of therapy rather than no therapy at all. And then the last iteration of that would be the switching of therapy within the anabolic class. And there you're in, I would have thought, a completely evidence-free zone. And my own instincts would be to try and hold fire from doing that until at least some period of anti-resorptive had been undertaken, because otherwise it would become very confusing, to have had 6 months of teriparatide or a biosimilar, followed by 9 months of romosozumab or abaloparatide before, God forbid, another fracture arises and one really doesn't know where to go. So my instincts would not be to switch around in short term within the formation stimulating class, but to retain the right to use the anti-resorptives if confidence had collapsed in the formation stimulating agent because of an intervening fracture.
Thank you. And maybe now a more global question regarding treatments. How cost-effective is treatment for patients at very high risk of fracture?
Really good question. And as we speak, our National Institute for Clinical Excellence, which has made a bit of a name for itself, unfortunately not always a good name for itself in osteoporosis, is beginning to deliberate just that issue for the newest agents that have been approved by the regulatory authorities. But let us go right back to where teriparatide is viewed by health economic minded policymakers. And if one were to use that paradigm, then around a 10-year risk of a major osteoporotic fracture of 40%, however it is reached, was able to balance the elevated cost of teriparatide in contrast with the very inexpensive use of alendronate or intermediate cost of denosumab when one expressed it as cost per quality adjusted life years saved. So I would have said that we are in an arena where that reaching of 30 to 40% major osteoporotic fracture 10-year risk is likely to be the area where cost utility is going to be demonstrated. But it still remains to see where policymakers in different countries decide they would authorize the use of these agents. But as I've shown you, getting to those levels of risk is really not going to be that difficult to do, as you saw in that slide which showed at different ages the combination of previous fracture, glucocorticoid therapy, and recency of that fracture. So there are going to be plenty of patients that are eligible for cost-effectively use romosozumab, teriparatide, abaloparatide, and biosimilars. The question is, where in that range will the sort of economically minded policymakers allow us to use those agents?
Thank you. Another question from Dr. Grigorier is asking if you think that now that we will adjust for recency, will that obviate the need for a country-specific definition of very high risk?
I think yes is the answer to that. I think that particularly if you use the FRAX approach to recency, that will have used, in order for FRAX to be applied to that particular country, the nearest or best estimate of fracture incidence rates and mortality rates in that population, so that there ought to be a country specificity of that estimate built into it. Clearly, the register-based and the sort of wider expert consensus-based systems are not quite so clearly nation-specific as the FRAX approach is, but those provide perhaps a more easy to understand operationalization. Two grade 2 vertebral fractures plus a t-score below -2.5 is easy for somebody to understand, and that might be a more convenient starting point for some practitioners, particularly if they're in primary care or in sort of general internal medicine practice. But I think that for the person who wishes to have a nation-specific approach, the FRAX approach certainly permits that well. It's albeit a little bit more complicated, as you saw with the translation from the 10-year probability to the use of the anabolic agent for very high risk.
Thank you. And I think that will be the last question, as you know, the time is running, but an important one. Is there a difference between very high risk associated with imminent fracture and very high risk associated with other fractures?
I would have put The short answer to that is no, because the two are the same. But I would have said that this question is better phrased as, is there a difference between very high risk as associated with imminent fracture or previous fracture and very high risk associated with other risk factors that are not a previous fracture risk? And that is interesting because in that slide where Eugene McCluskey and John Canis estimated how you reached the red very high risk, you saw how important the previous fracture in the recent past was. And it was quite difficult with other risk factors on their own to get to a very high risk. So family history or smoking or secondary osteoporosis and so forth on their own, they can cluster together in individuals, but you really have to get them all together in a very elderly person to get to very high risk. Whereas once you get to have had a fracture in the recent past, then it's really not very difficult to get to the very high risk group. So although other clinical risk factor constellations are relevant in very high risk, I do think that in the main, for practical purposes, we're talking about the very high risk associated with a recent fracture.
Thank you. And I think it's time to conclude. I'm sorry we don't have time to answer all the questions, but I would like to thank you all for your participation in this webinar, and we hope that you enjoyed this session. We will post the recording of this webinar on the IOF website, and you will also receive the link by email tomorrow. You will be prompted to fill in a survey immediately after this webinar, and we would appreciate your input and comments. I would like to thank again Amgen for the support. And last but not least, if you have any questions, comments, please do not hesitate to send them to webinar@osteoporosis.international. Thank you again, Professor Cooper, for this outstanding lecture, and goodbye to everyone.
Thank you very much.